Hi, I'm Glenn from Speak Life. We like to see all things through the lens of Jesus, including the issue of life and death. Just 2 weeks ago, Peter Singer, an Australian ethicist, came on to UnHerd to discuss some of his more controversial views, including his views on euthanasia. They touched in the discussion on the experience in Canada, and instantly I thought, I want to get to talk to somebody in Canada who knows about medical assistance in dying and who can think through these issues with us from a Christian point of view. And I'm very glad that we've actually got Dr. Ewan Goligher on the line. Dr. Goligher, thank you so much for joining us.
Hi, thank you so much, Glenn, for having me. It's my pleasure to be here.
So can you introduce yourself to us?
I'm an assistant professor of medicine at the University of Toronto. I practice intensive care medicine, and in the course of working in the intensive care unit, care for a lot of patients who are and their families who are working through end-of-life care issues. I'm also a physician scientist. I run a research program, and I also write and speak on issues around end-of-life care ethics, especially to help the Christian community think about these issues.
You're also the author of a book called How Should We Then Die? Tell us the origin of that book and what you hope for that book.
Yeah, I started working on that book several years ago. It's the fruit of a lot of thought and discussion with others about the issue of physician-assisted death. I didn't really spend too much mental effort on medical ethics, to be honest with you, aside from those issues that arose in the course of my practice, until assisted death was legalized in Canada about 10 years ago. And then it became very clear that those of us who opposed the practice would have to be able to give an account of why we were against it. And so the book is basically the result of years of reflection and a concerted effort to develop a kind of approach and to find the right language to explain to people why intentionally killing an innocent person is wrong, what are some of the flawed assumptions behind this practice, why we should oppose it, and ultimately how to wrestle with the questions about meaning and value that really underpin the whole conversation. And so what I'm hoping for the book is that it equips people to talk to their neighbors, their friends about the issue in a way that's informed and thoughtful and really gets to the root issues, the questions about what makes life worth living even when we have to suffer. I think fundamentally that's the question that we have to wrestle with when we think about this issue of assisted death.
Now, as a Christian, you're used to thinking in moral terms and gospel terms about life and death and ethics in that regards. But in your training, was there a lot of time given to medical ethics?
Well, I wouldn't say there was a lot of time given to it. It was certainly part of the core medical school curriculum. So at intervals, we would discuss and address different issues. Traditionally, medical ethics over the last few decades anyways has been characterized by a kind of principle-based approach where there are 4 basic principles that we're taught to follow, but really there's no underlying coherent framework for the basis of these principles and so on. So, as physicians in training, we're drinking in everything that we're hearing, and those principles come to really form and shape the practice. And in many ways, they're good principles. But I never really had to grapple with sort of the underlying questions of why until those principles started to seem to lead in directions that were very concerning to me. So, for example, many people will cite the principle of respect for autonomy as the basis for the appropriateness of causing a patient's death upon their voluntary request. And so, I was forced to really grapple with the underlying why of ethics in healthcare and more generally.
So what are those 4 principles? There's respect for autonomy is one of them.
Yeah, the first and really has become the foremost is respect for autonomy. There's also the principle of non-maleficence, or first do no harm, that many people will have heard of. There's thirdly the principle of beneficence, which is the principle that we ought to do good for the patient. And then finally, the principle of justice, which is that we, in making decisions about healthcare, have to consider principles of fairness in society as well. And one of the challenges in the practice of medicine is balancing these principles. And I would say that over time, the principle of autonomy has come to be kind of the basis for all of the other principles, and is increasingly seen as the kind of foundational principle in the practice of medicine.
And we'll think about that in regard to Peter Singer as an ethicist who was from Melbourne and has been at Harvard for many decades and has been at the leading edge of all sorts of ethical questions. I think he would describe himself perhaps as a utilitarian, but from that utilitarian basis has forwarded all sorts of views, and perhaps for the Christian, these impinge on questions of sanctity of life at the beginning and at the end. And I was watching this interview that he gave just a couple of weeks ago on the UnHerd channel, and I just thought I'd like to get your reflection on some of it. But you've sort of come across Peter Singer and some of his views before?
Yeah, I mean, Peter Singer has been described as the most influential living philosopher, which is, a lofty title, but probably appropriate. It's pretty striking, I would say, over the last several decades. Society has shifted significantly in terms of its kind of mores and values in ways that align more and more with views that he's been articulating for the last many decades. So there's no question that anytime you start wrestling with issues around end-of-life care ethics, never mind everything else, Singer is a significant voice that you have to wrestle with. And I think one of Singer's great strengths, I would say, is that he's incredibly accessible. So he writes for a broad audience, so he's easy to read. He's also very transparent and honest, and allows his conclusions to lead him to places that many other people would not be willing to go. Questions like infanticide and so on. So I think for that reason, he's been an effective and influential voice, and really has to be taken very seriously when we come to grapple with ethical issues.
Well, Freddie Sayers here is speaking about some of the controversies that Peter Singer has been famous for, but actually saying that over the last 50 years, society in some ways has been catching up to Peter Singer's views. Here's the way that Freddie Sayers speaks about it, and here's how Peter Singer responds.
When you first published those books in the 70s and the 80s, and some of the arguments around the case for abortion, up to and beyond term limits, the case for assisted dying, those things were considered very out there and controversial. Do you feel that the world has come closer to you during that period?
Yes, I think definitely on these right to life or sanctity of life issues, life and death decisions in healthcare, I think the world has moved quite perceptibly closer, because at the time when I started writing about them, there was nowhere in the world where voluntary euthanasia was legal, and also, voluntary assisted dying, if you want to distinguish that, the idea that the physician can prescribe you a drug but not actually administer you a lethal injection to end your life, that also was not legal.
Can you help us with that distinction between voluntary euthanasia and voluntary assisted dying?
Yeah, so this is a challenging area for many people because there's a bit of a word salad around all of the terminology. I actually don't think Singer used quite the correct terminology. I think what he meant to distinguish was voluntary euthanasia from voluntary assisted suicide. So in voluntary euthanasia, the healthcare practitioner directly administers the lethal drug to the patient intravenously. And in voluntary assisted suicide, the practitioner prescribes a lethal drug that the loved one or that the patient, then actually ingests for themselves. So they're committing suicide with the assistance of the healthcare practitioner. Morally and ethically speaking, there's no real significant moral difference, and I think that's kind of universally agreed. But from a practical point of view, because many people are sort of more comfortable having a lethal injection administered to them than actually ingesting a lethal substance, in jurisdictions where both are legal, euthanasia is far more popular. And if only assisted suicide is legalized, then the practice tends not to grow as widely or as rapidly as euthanasia does. So there's a practical distinction, although not really a moral distinction.
Because the patient is much more reticent to give themselves the lethal injection than to have somebody else do that. Is that when it comes down to it, it becomes much more difficult to do the act themselves?
Yeah, that seems to be the case. I don't have data to say exactly why, the underlying psychology, et cetera, but clearly people vastly prefer euthanasia over assisted suicide.
Interesting. Well, Singer goes on to say both practices have expanded much further than he had thought they would back in the 1970s.
Now it's legal in many countries and increasingly in the United States. It's more states. I think it's probably up to about 15 states of the US now, including California. Formerly Catholic countries like Spain and Portugal, so it's not only the Netherlands, and all of Canada, pretty much all of Australia now. I'm rather surprised that it isn't legal in the United Kingdom yet. I'm not quite sure what's holding that discussion back, but I was just in France. It's being discussed in France. Again, I don't really know what will happen. So on that issue, yes, world has moved much closer.
It has been discussed very often in the United Kingdom. It's been sort of rejected consistently up until now, and it seems like Keir Starmer and Labour will get in at the next election, and it seems likely that legislation around euthanasia will again be presented to Parliament. Ewan, you're from outside the UK. I'm an Australian and not a Brit myself, but do you have any views on why the UK might be holding out against this particular tide?
Well, I've actually wondered that myself, because I've watched with admiration as the UK has held the line on this issue. I think one of the factors for sure is that the UK has been a world leader in palliative care. In fact, the palliative care movement was started by Dame Cicely Saunders working in London, I believe, in the 60s. And so I think the strength of that movement in the United Kingdom, and the understanding that the process of dying can be an opportunity to flourish and not just a season of suffering, I think has sort of fortified many in Britain against the practice. I'm sure there may be other factors as well, but I think it's a really interesting question to consider.
That's very interesting. I mean, euthanasia is just a word that means good death. And I guess if you've got an alternative that really is, as regards palliative care, a good alternative, then it starts to be easier to say no, I guess. I was very struck in your book by the analogy you use, that if you're walking along a cliff top and you see somebody sort of hanging on by their fingernails, and if they say, just inject me so that I'll let go, and you refuse to do that, it is probably morally incumbent on you to alternatively do something else. Like if you're not going to help them go off the cliff, you probably should help them in the despair that they're in. And it sort of makes me ask the question, if we're going to say no to euthanasia as the church and as society, what sort of church and what sort of society do we need to be in order to say no to that and say yes to something else?
Yeah, that is such an important point. I think one of the reasons that the public embraces euthanasia is because they're genuinely afraid of the dying process. And in medicine, I don't think we've done a terrifically good job of educating people about the options that they have for the control of pain and symptoms as they journey towards death, and how effective good palliative medicine can be. So I think the first thing to do is to reinforce the ability of palliative care to ensure that patients live to the fullest even through the dying process. And I think it's really important to highlight that most people who are seeking assisted death do so not because of uncontrolled physical pain or discomfort, but rather really because of more existential reasons around loss of autonomy, feeling like a burden, a sense of worthlessness, and just seeing no point in going on with life given that you're in steady decline. And those are a fundamentally different set of problems than, say, the kinds of problems that people are afraid of around physical suffering. So what kind of church and what kind of society do we need to be to care for people well through the dying process? Well, we need to, first of all, make sure that good medical care is widely available to people in the dying process. And secondly, we need to be communities that gather around people so that they can see how much they matter to themselves. I think the temptation for the dying particularly those who are living in relative isolation, is to doubt their own worth and significance and to see life as pointless. And so our task really becomes to remind them just how much we matter by our words and deeds toward them. And I think that's a particularly important task for the church.
That's a beautiful word, because, what is the alternative to autonomy and independence? I guess it's kind of interdependence and care. How can we be churches like that? How can we be societies like that? So Peter Singer has said, okay, euthanasia has kind of increased in certain parts of Europe, in 15 states, I think he said, in the United States, all across Canada, in certain states in Australia. What does he say next?
On essentially the idea that abortion is a woman's choice is something that has been much more widely accepted as well.
I mean, if we just take the assisted dying case, it's also, whilst becoming more accepted in law, it's also become much more of a political argument, hasn't it? It feels like there's been the beginnings of a backlash against it. Certainly in Canada, for example, it's become very controversial, and a lot of people point to the experience in Canada as problematic, worrying.
I don't really agree with that.
Okay.
My reading of Canada is that they had a somewhat conservative law allowing physician-assisted dying in case of patients who are terminally ill. They've broadened that out to include people who are incurably ill rather than just terminally ill. And they're now contemplating, which would be in advance of anywhere else, the idea that if, for example, you have early onset Alzheimer's, you could say that you don't want to die now, but you would like to die when you reach a certain point. And that generally is not legal elsewhere.
So what is the Canadian experience? When did medical assistance in dying come in? Was it controversial at the time, and has there been a backlash?
So assisted death was legalized technically by the government in 2016. There was a Supreme Court case that was decided in 2015 when the criminal law prohibition on physician-assisted death was struck down, and the government was ordered to pass legislation to legalize it the following year, which they did. So since 2016, the practice has grown steadily in Canada. I think in the first year it was legalized, there were about 1,300 deaths by assisted death. And last year, or 2022, the last year for which we have official numbers, I think the number was something like 13,000. So in terms of acceptance and uptake and growth in the practice, it's really grown quite dramatically. As Singer said, when it was first legalized, it was restricted to those for whom death was reasonably foreseeable. Now that was already a pretty subjective and sort of debatable matter of judgment, just when death became reasonably foreseeable. But then in 2021, the law was changed to remove that requirement. So now people who were grievously and irremediably suffering, but not necessarily facing or dealing with a terminal illness, say for example, chronic disability, could seek assisted death. And that, I think, was a significant game changer, because up to that point, the public's perception was that this was relatively well controlled and limited. And after that was legalized, in some sense, the floodgates opened. Not in terms of,
When was that change? When did that change happen?
This was 2021.
Right.
And since then, that's when we've started to hear stories in the media about people living in poverty or with significant disability and no other options, seeking assisted death. And those are some of the stories that have made their way around the world in news headlines to raise concerns about what is happening in Canada. So, I would emphasize that those cases are still a small minority of the total number of assisted deaths. But one of the challenges in the Canadian conversation has been just how far are we willing to go to permit this? Will we permit this for people with mental illness? Will we permit this if people want to make an advance directive? Will we permit it for mature minors? And the trouble is that once you accept the idea that death can be good for suffering, that it's a kind of effective treatment for suffering, well, all kinds of people become eligible potentially for death. And so it's very hard to contain once you let the horse out of the barn, so to speak.
And especially if suffering, if we don't have a category for meaningful suffering either, which in the utilitarian calculus is pretty much the assumption. That's where you begin. That suffering is as bad can be, really, and pleasure is as good can be. And to eliminate all suffering means at times eliminating sufferers. Unless we can have a category for meaningful pain, meaningful suffering, but it seems like we don't really have that anymore.
Yeah, I think the idea that a life lived with chronic, grievous, and irremediable suffering could still be a life that's worth living seems like almost an absurdity to many people in society now. It's very hard for them to make sense of how such a life could be worthwhile or significant. And I think in the book, I try to draw out the fact that this reflects an underlying or deeper problem, that we think we're responsible for finding our own meaning, that meaning is not something that's given to us. It's something that we have to create for ourselves. And as soon as suffering comes along and makes us unable to create meaning for ourselves, well, we find ourselves feeling utterly meaningless and therefore see no point in going on with life. So really this desire, demand for assisted death reflects, I think, a kind of broader crisis of meaning in the West, the challenge of making sense of what makes life worth living in the first place.
And it seems to me to raise the question of how we identify the marginalized, the weak, victims, because I think from a Christian point of view and from a post-Christian point of view, identifying the truly marginalized, the truly weak, and supporting them and being the kind of society that looks after its weakest members is a virtue. I think that's a virtue in a Christian worldview. I think it's a virtue in a post-Christian worldview. But I guess the big question becomes, how do you identify those weak, those poor, those marginalized? And I think in the UK, the story of the pro-euthanasia side, they've been very good at bringing forth those stories of unyielding, unremitting pain and suffering. And it's often a story that's spoken by someone that we deeply respect, Terry Pratchett, let's say. Just a wonderful author. I devoured Terry Pratchett novels as a teenager. And we all love Terry Pratchett, and we all hate Alzheimer's. And we hate that degenerative condition and what it's doing to Terry Pratchett. And he comes forth as a very worthy object of our compassion and our care. And how do we make sure that Terry Pratchett is in charge of his life and his death? And that's kind of forwarded as the compassion story that really does win hearts and minds and sways people. How can we tell a better story as Christians about who some of the other vulnerable people are when it comes to euthanasia?
Well, I think that the first thing that we have to do is to get a lot more clarity on the question of whether ending someone is a way to show respect for them. There is no question that everyone agrees, whether we're for assisted death or against assisted death, that suffering is tragic, that people matter, and that we ought to respond to their suffering and their situations with care, concern, and real solutions. The question, I think, is whether death presents itself as a compassionate solution or not. And what we're often told is that by ending people, you're rendering them better off. You're giving them what they want, and you're empowering them, and that's how we're expressing value towards them. And I think the first thing we have to see that, in fact, when you choose to end someone, what you're actually saying is that they don't matter anymore. Their existence doesn't matter anymore, and therefore they don't matter anymore, and we no longer need them with us. So in assisted death's effort to show dignity and respect for those who are suffering, it actually profoundly devalues them, because it's a statement that's saying your existence no longer matters. It's no longer good that you're here. So we need to understand the way in which ending someone actually devalues them. And so it essentially takes that option off the table. Yes, we agree we need to show compassion for those who are suffering, for those who are marginalized, those who are weak, but is causing their death actually a way to do that? And I think that the other thing I would say is that we need to really get clear on the nature of vulnerability here, because not only are people vulnerable to assisted death when they have external circumstances that make life very difficult for them, poverty, disability, and sickness, but I think people are also vulnerable in the sense that if they don't have the resources to find life meaningful when they start to suffer, and death seems like the best option, that's a different kind of vulnerability. I'd call it a kind of internal or spiritual vulnerability. And so I think all these different forms of vulnerability need to be addressed. Social circumstances, marginalization, especially in our churches, looking out for those who are lonely or those who are disabled, to ensure that we find ways, whether through hospitality and various ministries, that we ensure that we show them how much they matter, that they're not alone and that they're valued. But also just recognizing that our society has become profoundly vulnerable to the temptation to seek death, because we struggle to see how much we matter, and because we struggle to make sense of a life worth living in the face of suffering. Like we said, we don't have the spiritual resources to live with suffering. So let's say there's many layers of vulnerability to think about, but at the end of the day, the critical thing is to recognize that causing someone's death is not actually a way to express value, to show them their value. It's not an act of love.
Right. Let's get back to Peter, and he's discussing the experience of Canada.
My reading of the controversy in Canada is about how far this should go, and there's not a serious likelihood of it being wound back, as I see it.
Would you agree with that, Ewan, that having brought MAID in and having expanded the scenarios in which euthanasia is applied, is there any way of getting the genie back into the bottle?
Well, I think the first thing is for people to recover or recognize the significance of calling into question the sanctity of life. And another way of putting that is to help people recover an understanding that people are intrinsically valuable rather than merely extrinsically valuable. But I think it's going to take a kind of paradigm shift for a society, because once you accept, as I said earlier, once you accept the notion that death is good for suffering, then it's very difficult to sort of retrace these lines and put and recover limits on the practice. I think one could imagine political movements that curtail the practice to some extent, that say we've gone too far and we need to redraw some lines. But I think there are two challenges to that. First of all, that ultimately every assisted death is a kind of tragedy, and it's not just cases where people are ended who were because they were in poverty or marginalized. Those are especially tragic cases, but we need to see every case of assisted death as a tragedy. And secondly, people have drawn the connection between the desire for death and the right to death. And once this becomes perceived as a right, and putting limits and curtailing the practice, you're curtailing people's rights, becomes a very challenging social and political conversation. So, to be honest with you, it's hard for me to see the way forward in the absence of a dramatic social shift, recovering a vision for the intrinsic value of human persons.
You've mentioned the difference between intrinsic value and extrinsic value. Can you just elucidate on that?
Yeah, so this is a really critical conceptual set of categories to have when we're thinking about the ethics of assisted death. So when we say that people are intrinsically valuable, it means that they matter not by virtue of what they can do, or not by virtue of their utility or usefulness, but simply because of who and what they are. They are to be treated and recognized to be an end in themselves. Whereas if something has extrinsic value, we value it because of its utility, its usefulness. And one of the important differences between intrinsic and extrinsic value is that if you have extrinsic value only, then you can lose your value, because if you become useless or you no longer have utility, well, then you've lost your value. And so things that have extrinsic value Their value is contingent, dependent, variable. And essentially what I'm arguing in the book is that assisted death views people as if they have extrinsic value only. It treats them as if their value is contingent and variable, and once they've lost their value, then it's appropriate for us to end them. Now, it seeks to make the person themselves, the arbiter of their own value, so it tries to respect autonomy in that sense. But ultimately, what we see are people being invited to treat themselves as if they have extrinsic value, and forgetting that, in fact, they have intrinsic, unchanging, unconditional value that always ought to be respected. And so I like to put it this way, that you can't call into question the value of a person's existence without calling into question the value of the person themselves. There's this deep connection between respect for someone's life and respect for the person themselves. And by permitting assisted death, really what we're saying is people don't have intrinsic value, they just have extrinsic value, and if they lose their value, then it's okay to end them. So the practice has this kind of built-in devaluation.
Right. And it puts everyone on a dimmer switch rather than on an on-off switch. You know, a dimmer switch can be dimmer or brighter. On-off is 100% or 0%. And I guess from a more faith-based tradition, the sanctity of life is trying to do justice to that kind of concept. It's discrete on-off, not continuous dimmer switch. You in the book speak in terms of the difference between the intrinsic and the extrinsic. It's interesting that Peter Singer in this interview actually talks about, when I talk about abortion and euthanasia stuff, I'm talking about sanctity of life type issues. And I guess Peter Singer sees that the on-off switch, the 100% value that's equal, that intrinsically resides in every human being, is a faith-based. It is a holy thing. It's a sanctity issue. And I just wonder whether he's actually right about that to some degree, that it is the Bible that's given us this view. You know, it's the Imago Dei, it's the image of God in all people that's been secularized, and you can use more religious-sounding language like sanctity, and you can use more natural law-type language like intrinsic value. But at the end of the day, we get this from Scripture more than from logic, is my hunch. What do you think about that?
Yeah, this is such an interesting question that I've wrestled with a lot myself. You know, I would say Singer would really agree with you about that. One of the things that he's done really kind of clearly in his work is draw out the implications of shifting from a Christian vision of human origins and value to a Darwinian vision of human origins and value, where, you know, and by Darwinian, I'm talking about kind of naturalistic interpretations of evolutionary theory, where people are seen as purely the consequence of an undirected, unguided, random process of evolution over time, where God is not involved or in the picture at all. And he would argue that cancels out any concept or possibility of the image of God, and then concludes that for that reason there's no fundamental difference between humans and other animals in terms of their value, moral significance, etc. So he calls that a Copernican revolution in ethics, and really tries to emphasize the significance of rejecting the image of God concept. You know, in my own reflections on this, I would say I would distinguish between knowing that people matter and knowing why they matter. I would say that you will be hard pressed to find someone who doesn't know that people matter, who at least doesn't know that they themselves matter, that they ought to be treated with respect and fairness. And I think there's a biblical case to be made that this kind of knowledge is something that's granted to us, but it's, you know, when I talk to my colleagues and my friends, and even in the assisted death movement itself, we see that desire to show respect for human value, even if they reach the wrong conclusions in their attempts to do so. So I think we can say that we know that people matter, but then the question becomes, well, why do they matter? Where does this intrinsic value come from? And I think you can know that people have intrinsic value without actually knowing why they have intrinsic value. And the significance of Scripture, the image of God concept, and the gospel is that it gives us the explanation for why people matter and therefore helps us to see even more clearly just how much they matter. So obviously the question of whether people matter and why they matter are very tightly linked together, but one's an epistemological question, or a question of knowledge, and the other is an ontological question, or a question of the being or foundation of value. And I think that it's appropriate for us functioning in the public square to draw on what I think is natural knowledge, or what other Christians have called the light of nature. We can leverage that to our advantage. But of course, then it raises the question, well, where could this value possibly come from? And that's where we can be faithful Christian witnesses in pointing to the fact that we're created in God's image and loved by God so greatly that he sent his own son to redeem us. Those become very powerful Christian beliefs that help us to sustain and clearly envision just how much we matter.
Yes. Yeah. I mean, I would say, yes, we all have a sense that we all matter. The idea that we all matter equally, I just wonder, looking around the world, doing sort of comparative anthropology, the first manual of midwifery in the first century, this Roman manual of midwifery, section 1 is on how to identify the offspring that is worth raising. Aristotle himself would think that men are more valuable than women, and masters are more valuable than slaves, and citizens are more valuable than barbarians, etc., etc. Just how natural it is, and whether we are repaganizing, actually. That a post-Christian society that starts putting everybody on the dimmer switch is repaganizing, but doing it for so Christian-ish motivations, out of compassion and healthcare and all these sorts of things, which is quite a dystopian vision. Ewan, tell me, as a doctor, how does it change your profession? How does it change your role? How does it change your calling to now be somebody who, first do no harm, and you probably didn't take the Hippocratic Oath, but at least the Hippocratic Oath kind of forbids things like this. And then all of a sudden, this is now an expected part of your role? I mean, what does it do to the profession?
Yeah, well, we took the Hippocratic Oath when we graduated from medical school.
Okay, you did.
But it was a heavily modified, heavily attenuated version of it, obviously. I think that this represents the way, it sort of signifies the way that medicine is shifting from a profession that is focused on the good of healing and the moral value of caring for the body and recognizing and predicated on the goodness of the body, to one that basically sees its role as one of personal empowerment. Others have written about this, contrasting what you might call kind of traditional medical practice oriented towards healing versus the provider services model, where physicians are seen almost like technicians, and the patient walks in, tells you what's good for them, and then asks for specific services, and then you act accordingly. So there's a tremendous loss of professional moral judgment, because it's no longer really my place to tell the patient whether death is good for them or not. Really, my place is only to tell them whether they're eligible for it under the law, and if they are eligible for it, to make sure that it's accessible to them. And so it really changes the role. You move away from being a professional to being much more of a technician. And I think that that creates challenges throughout all of medicine. This is not the only area where there's a tension between what doctors think is good for patients and the need or expectation to absolutely respect patient autonomy. This shows up in other kinds of end-of-life issues as well, never mind other parts of medicine. And so it really does shift the conversation, and I think one of the tasks of those of us in medicine who continue to want to practice in accordance with the intrinsic value of persons have tremendous work cut out for us to sustain a traditional ethic of medicine. I think there are efforts to do so, but I think that patients going to see their doctor can anticipate questions, them being asked sort of what they want, in a way that perhaps 34 years ago would not have happened. And in some respects, it's a bit of a pendulum, because perhaps in the past, medicine was too paternalistic, too tempted to make decisions for patients without involving them in decisions in their own care. And now the pendulum is swung extreme to the other side, where sort of seeing the patient as the one who directs all their care without the doctor having any sense of what's actually good for the person per se.
And we might get into financial issues as well, because both the experience of the NHS here, but also in Canada, if you've got a national kind of health service, all sorts of financial pressures happen at the national level, let alone financial pressures on the individual patients as well. And that's kind of where Freddie Sayers goes as well, and asks Peter Singer, are there troubling aspects? Is there anything that would trouble you about the Canadian experience?
What limits would you put on it then, on that example? We did a study here at UnHerd, and I think 4.1% of all deaths in 2022 were assisted dying.
Yeah, that's not surprising, right? I mean, what percentage of deaths are due to cancer, right? It's much larger, and it's not surprising that many people who are dying from cancer and whose quality of life has fallen to a point where they don't regard it as positive, don't want to go on to the very end. It happened to my brother-in-law, sadly, my wife's brother. And he was probably fairly close to dying, but certainly his death would be counted as assisted suicide. He used the legislation. He took the drug with his family around him. Maybe he would have had another week or two of life, but it wasn't. It was already not good at that point.
So there's no quantity. There's no volume of uptake that you would consider intrinsically worrying. If it turned out it was 10% or 20% of deaths, would you start thinking, uh-oh, it's going too far, or is...
No, I wouldn't. I would want to look at the number of people who are dying from conditions that are distressing in their last week or two. I would also want to know what the prognosis was for people, right? If there were people who had lots of life left, then that would be disturbing, not necessarily that the law was wrong, but that we couldn't make their living conditions good enough for them to want to live right out to the end.
And there have been cases of that, haven't there? Younger people with mental health issues or depression who are seeking to choose that option. Is that something that...
Well, I think depression is a difficult case, because obviously when people have mental illness, you might say, well, are they really making a considered judgment when they're in a suitable frame of mind to make that judgment? If the depression were a temporary one, then I would certainly not want them to be able to make that decision. But if, as in maybe one of the cases you're thinking of, is a woman in Belgium who had clinical depression for 20 years and had been trying to get it treated, many treatments had been tried and failed, and she said her life was just agonizing because of that. I wouldn't say that was not her decision to make. Again, I'd regret that she couldn't find a cure or a way of living better, but in the end, I think if you're trying for 20 years, that is your decision to make.
We'll get to the financial pressure in a second, but we've spoken already about we fail to have a category for meaningful suffering that is ongoing and stubborn and will only increase until death. And at that stage, the disability community, I think, can rightly feel shocked and aggrieved that we're valuing them less. So there's one community, the disability community, but then there's also mental health issues. And if we foreground autonomy, when actually precisely the issue is that mentally I'm not in a good headspace to make decisions about my life, are we kind of casting them adrift and handing them over to their own choices, which are not very good for them? What does it do to open up the scope of euthanasia to mental health issues as well?
Well, it really creates a profound dilemma for the people who are assessing patients for assisted death. And, one of the interesting things is that psychiatrists are often called upon to evaluate whether mental illness may be contributing to a person's desire for death and whether they're competent to make medical decisions of that sort. And I think for psychiatrists, it creates a huge challenge because for a long time we've taken it for granted that the very desire for death is sort of necessarily implies some type of mental illness. And once you accept the idea that the choice to die can be completely rational, then it becomes very difficult to sort out just to what extent a mental illness is affecting a person's judgment versus them making a rational choice. And I'm sure there'll be many border cases where it becomes a matter of almost personal judgment with a lot of differences from psychiatrist to psychiatrist about whether someone's in an appropriate state of mind to make a decision like this. And so many in the Canadian psychiatric community were sort of very opposed to making it legal just for this reason, that it would be so hard to decide who actually had the capacity to make such a decision. Never mind the fact that mental illness can often be variable, that it can often recover in unexpected ways. And so, where ending someone's life obviously forecloses those possibilities. So it's been a significant challenge. At the same time, you can see how once you buy into the notion that death is an effective remedy for suffering, it becomes very tempting to offer it to people who are genuinely and very seriously suffering from a mental illness. These are deep forms of anguish and suffering that we need to take very seriously and show real compassion toward.
Yeah. So Freddie raises the issue of mental health, and Peter Singer is fairly unmoved by that, but the conversation goes on.
So I suppose to flip it around, what would be the signs of, what would it take for you to be worried then? What sort of scenarios would you start to feel like this is now indefensible, or we should, even if someone wants it, not allow it?
So I think it would depend on the people who were asking for it. If they were people who generally were from the poorer strata of society, and you felt maybe they were not getting sufficient support, they were maybe not getting good health care, or perhaps they were trying to save their family money because to get decent health care they had to spend money that the family did not really have, or that would trouble me. But in fact, where we have the statistics, it seems like it's generally the more educated and better off part of the population that is using the legislation, and not disadvantaged minorities. So that's why I don't think that is in fact a problem, but that would be one thing that worried me.
So how do financial pressures play into this at the individual level, the family level, but also a kind of a nationwide level if you've got like a national health service?
Yeah, this is a fear that financial pressures could, at a health system level, could drive the provision of euthanasia. And there's no question that there seems to be certain specific reported cases where people are turning to euthanasia because they really have no other options in terms of social support, being able to afford clean environments where their chronic illnesses would be better controlled, or people just living in poverty and having enough of it and turning to assisted death. Those cases have been reported. And even though that's certainly not the majority of cases, the available data suggests that the vast majority of people seeking assisted death are, wealthy, white patients who, don't fit into our typical conception of what a visible or marginalized minority looks like. But nevertheless, the question I'd love to pose to Peter Singer is just how many of these marginalized cases need to occur in order to say that the practice as a whole is unacceptable or impermissible. Is 1 out of 10,000 a year too many? Is 2 out of 10,000 too many? Just where do you draw the line on this? And so clearly he admits that kind of pressure and marginalization would make it very concerning. But just where is he and other advocates for the practice actually prepared to draw the line. I think it would be interesting to hear what he would have to say about that.
There's a similar parallel and interesting to think through about the death penalty, and I do wonder, how many people are against the death penalty for precisely what you just say, because there might just be one innocent person put to death, and it doesn't matter if 499 have been guilty. Just the possibility that one innocent person's life is taken is enough for a lot of people to be in a blanket way against the death penalty. But that, for some reason, that logic doesn't really seem to carry over to the euthanasia debate.
Yeah, that's such a great point and such an interesting parallel. And I think it's, at bottom, it's because once people accept that, this is a compassionate way to respond to suffering and an appropriate way to respond to suffering, the focus becomes all about finding a way to make sure it's safe and effective and so on. And the challenge in Canada, and elsewhere has really become, how do you make sure that these vulnerable patients don't suffer as a consequence? And it's very challenging. So I think your point is really well taken.
I just wonder if we need to get better at unmasking what is compassionate, the slogan of compassion, unmasking it, and trying to forward a more rounded, grounded, engaged, sacrificial vision for compassion. You see it at the other end of life with abortion. I mean, in a post-Christian society, how else is abortion going to be forwarded except as it's healthcare? It's about bodily autonomy, it's about gender equality, and it's compassionate, which are all incredibly Christianish kind of virtues that the issue is kind of clothed in. And even those who kind of forward a practice that is not Christian cannot help but do so in language that uses Christianish language of compassion, but uses it as a slogan rather than a kind of a virtue to be forwarded. So do we just own the fact that the stance against euthanasia might sound cruel, but it's cruel to be kind? Or do we somehow redeem the language of compassion and arrest it and tell better stories? I don't know. How do we speak about this?
Yeah, I think the first thing to do is to unmask the way in which euthanasia actually devalues people rather than showing value. I think the desire, the kind of logic behind it is that this is the way we show people that they matter. This is the way we respect their autonomy. We respond to their moral significance. And what I tried to do in the book was to show that this practice actually treats people as if they only have extrinsic value, not intrinsic value. It doesn't treat them as if they have intrinsic value. But if they have intrinsic value, then it's always good that they're here. And so we will be forced to find ways to respond to their suffering that are actually more difficult and challenging for ourselves. And I think the word that you used there, sacrificial, is crucial because it's easy to go in, as a physician, it's very easy for me to go into someone's room and end them. Like, it takes relatively little training and medical skill and not that much time. Whereas to journey with them through their illness, to be continuously available to respond to their symptoms, that takes work, it takes time, it takes sacrifice. And I'd say that's true more generally for those of us who have people who live with chronic suffering and disability in our lives. There's a measure of sacrifice that's called upon. But in the end, it becomes beautiful because in responding to their value in this way, in journeying with them, which is really what compassion is really about, to suffer with, we remind ourselves of the beauty and significance of being human, and even in the face of difficulty and tragedy. So I think, to be honest with you, I think palliative care is such a good example of what genuine compassion looks like, and the way in which some measure of sacrifice is necessary in order to genuinely dignify the human condition.
That's beautiful. And you get to a beautiful spot towards the end of the book about casting a Christian vision for these issues about what is life, what is death, what is human value, what is the good life. Just as we finish, Ewan, can you just paint us a picture? You're a Christian as well as a doctor. Paint us a picture of how the gospel makes us see life and death and value and sacrifice and hope in a different light?
The gospel is so rich because it just speaks to these issues in so many different ways. I mean, what could help us to see the value of humanity more clearly than the fact that we were created in God's image, that God gave his own son to redeem us from our brokenness and rebellion, and that we will spend eternity in glory with God. This is a genuinely exalted vision of what it means to be human. And additionally, it sort of equips us to cope with suffering, because it gives us the theological and spiritual resources and equipment that we need to suffer well. And in the book, I particularly emphasize what are sometimes traditionally called the theological virtues of faith, hope, and love. And if we're able to approach suffering with a strong confidence or faith that God's purposes and power are at work, and hope that we will not always be left suffering, but that our suffering will ultimately be ended and that we'll be raised bodily to enjoy health in the future to come. And finally, that we are loved, that God is always with us even in our suffering, and that we were ultimately created to know him, to love him, to serve him, and to worship him. And suffering can't rob us of any of those purposes. Well, it equips us to be able to transcend suffering and to suffer well, and to suffer with those around us who are suffering to the glory of God. So I think the gospel, and that's just a brief summary. In so many ways, the gospel equips us to face this issue in a really effective and transformative way.
I love it. You've been very generous with your time, Dr. Goligher. The book is called How Should We Then Die? It's such a refreshing read, and I think it will be very useful for us, especially in the UK, as we face some of these questions here. Dr. Ewan Goligher, thank you so much.
Thank you for having me.